All right. Good evening, everybody. My name is Siobhan Statuta, and I'm delighted to be able to introduce you guys tonight to our wonderful speaker, Dr. Sylvester. We are excited that you're joining us for the National Fellow Online Lecture Series, which is sponsored by the AMSSM Online Fellows Education Subcommittee, the Education and the Fellowship Committees. So tonight we get to learn about mononucleosis in athletes. I'll be your moderator, Siobhan Statuta, and our speaker tonight is Dr. Jillian Sylvester. I will just take this opportunity to quickly encourage you guys to please also make note that we have a fantastic lecture besides ours tonight, but next week we're going to be hearing from Dr. Emily Krause. That lecture will be moderated by Melody Rubish, who is always fun to listen to. And the topic is going to be on endocrinology for athletes. And just as a reminder, I just threw in this slide. This is the endocrine system. So you guys, no matter how long you've been practicing, it's always great to get a refresher, particularly when we're thinking about how it applies to sports medicine and our athletes. So please make sure to join us next week, same time on December 7th for endocrinology and athletes. All right, so without any further ado, let's go through some ground rules regarding these talks. These talks are to serve as an adjunct to your individual program's educational programming. Okay, so you need to do your outside learning, but also we hope that this helps supplement your education. It's to provide fellows with direct access to educational experiences with experienced AMSSM members, and at times, guest experts in a variety of formats. We also hope that it helps assist you in preparation for the CAQ exam, which will be coming up in about half a year, so time is flying. Additionally, please mute your device's microphone, turn off your video, submit questions through chat. Include your name and program if you want. At the end, I will ask the questions during the question and answer portion based upon the questions you submit, and hopefully we'll be able to get to all of them. After the program, we really appreciate it if you can complete an evaluation, which will be sent to you guys at the end of the lecture. So we are going to learn about mononucleosis tonight from my friend, Dr. Jill Sylvester. Dr. Sylvester completed medical school at Penn State University in Hershey, Pennsylvania. She then commissioned into the Air Force and completed residency in family medicine at the National Capital Consortium's Fort Belvoir Community Hospital and fellowship in sports medicine at Uniformed Services University of Health Sciences, both kind of in the Washington, D.C. area. She served in the Air Force for 4 years, where she was faculty at the Scott Air Force Base, St. Louis University Combined Family Medicine Residency in O'Fallon, Illinois. She recently left the Air Force and joined the Sports Medicine Institute at the University of North Carolina, where she is an assistant professor in the Department of Orthopedics. Now, as mentioned before, we like to get experienced or experts to come talk to us. So why mononucleosis for Dr. Sylvester? She has completed some amazing research, some of which I think we'll be hearing about tonight, to advance our understanding of this syndrome that commonly plagues our athletes. Additionally, over the past 18 months, Dr. Sylvester has been working with some incredible AMSSM colleagues to update the AMSSM position statement regarding the diagnosis and treatment of mononucleosis in athletes. Some of these updates are presented here with full disclaimer that they are in draft form and may still change prior to publication. So just be mindful of that. But without any further ado, I would like to turn this over to Dr. Jill Sylvester. Let me stop the share. And Jill, thank you for joining us.
Well, thank you for having me. Let me share my screen and we will get started. So let's see here. We've got desktop 1, desktop 2. This is when I try to be fancy. All right. Are y'all able to see my screen?
I cannot.
How about now? My screen sharing the wrong one.
No, I can see that. You're screen sharing the wrong one.
I'm screen sharing the wrong one. See that?
Yes.
Okay.
I can see the notes pages.
All right. Well, you see on my notes and how I'm thanking you for inviting me and how I really enjoy this. So let's try this again.
That's perfect.
All right. Well, thank you so much. I really enjoy this, and it's great to be able to be here today and contribute a little bit to this awesome lecture series. As Dr. Statuta said, my name is Jillian Sylvester. I don't have any disclosures to really talk about today, except for the part that I am on the AMSSM, Mononucleosis in Athletes Position Statement Writing Group, and we've been working on these new updated position statements. So I'm going to foot stomp what's the CAQ board exam answer and what is currently represented in the 2008 guidelines. And it will be very clear what's current guidelines and what is presented as our draft of what may be to come. So stay tuned. But let's jump right in. So what is mononucleosis? It's also known as glandular fever. It's also known as the kissing disease. This is a viral syndrome. It's characterized by your triad of fever, sore throat, posterior cervical lymphadenopathy. But really, when we think about someone who's had mono, you're thinking about, man, they're just dragged down, tired, they're fatigued, got some URI type symptoms, some abdominal pain, myalgias, malaise, just not feeling great. And when we think about, the number one virus that comes to mind with this is our Epstein-Barr virus. And so 90% of cases of mono are attributable to your EBV. 10% do come from cytomegaloviruses. But for the purpose of this talk, we're really going to hammer down on the EBV side of things. Your HHV6, your adeno, your HSV, these can cause a mono-like illness, but they aren't consistent with true mononucleosis. Let's think about who gets mono. Well, we think about our college kids are the ones that we're going to be worried about, especially, in fellowship and as team athletes, our team physicians, we worry about our athletes. When you have your incoming freshmen, about half to 2/3 of adolescents will have had an EBV exposure by the time they enter a college. By the time they're ready to rent a car, about 95% of the population will be EBV positive. So, this is a ubiquitously exposed virus. Everyone's, practically has antibodies to it by the time they're well into adulthood. When we look at our young populations and we kind of try to see who is exposed early, well, Gares did a study in the United Kingdom and looked at 3-year-olds across the UK in rural, suburban, and urban areas, and then also looked at what was the population's socioeconomic status, what was their living situation, and the pattern that they found was that EBV positive status, presence of antibodies, was associated with 3-year-olds who lived in urban environments, who had household overcrowding, and who were living in rented and subsidized housing. So you think about that population density exposure. And now let's try to extrapolate that risk factor out to other populations. So coming from the DoD in my previous job, when we look at mononucleosis, we're seeing our highest incidence in recruits. And when you look at the Medical Surveillance Monthly Report, it talks about the top 10 bases that report mono, and the top 3 are basic training bases. The rest are actually in these bases that have a high amount of large troop operations. So your infantry units, and when we have a lot of people living in dorms and in barracks together. When we're then extrapolating out to maybe our college population and we're thinking about dorm life, is that that high volume of people living in close proximity is going to be an increased risk of transmission. So speaking of transmission, this is our kissing disease, right? So the most common form of transmission is through oral secretions, through saliva. It has been shown EBV is present in blood. It's present in other body fluids. That's not typically how it spreads. Vertical transmission is possible, but rare, and it has been isolated in breast milk. So you can find EBV in breast milk, but they've done studies where they've looked at mothers who have EBV, and they have had cohorts of your breastfeeding and your bottle feeding populations. And by 2 years, the incidence of antibody presence in the 2-year-old kiddos, they're equal in both cohorts. So overall, think saliva. Now, I'm going to go back to, first year medical school. Let's go back to microbiology, because conceptually, the clinical presentation of mononucleosis makes more sense if we think about how EBV invades and attacks the body. So it's a double-stranded DNA. It's transmitted through saliva. So enters through the oropharynx, enters those epithelial cells, and starts dividing. Now, the virus will either go back into saliva and will be shed through the mouth, or it's going to then proceed to go into the submucosal lymphoid tissue, right? It's going to go and it's going to attack its primary targets, which are the B cells. And so you're going to start to get DNA transformation, and in the B cells, you're going to start getting all this viral replication. You're making more virus. And then those B cells are just going to transfer like all throughout the lymphoid tissue, all throughout the lymphatic system. And so you're going to start to get start to think about your glandular mucosal lymphoid tissue hyperplasia in that respect. As you're making more virus, it's going to go into the bloodstream, and it's going to start to meet your macrophages. It's going to trigger that T cell response and your cytokine response, and you're going to develop fevers, and you're going to develop myalgias and some of those typical classical symptoms there. And then, as you're seeing that antigen continue to move throughout the body, it's going to meet your B cells. They're going to recognize it. You're going to get your plasma cells starting to make antibody, and suddenly you're making a lot of IgM antibody against your antigens. So thinking about how that kind of process forms in the back of your head as we kind of think about our clinical presentation, physical exam. And so, it's a weeknight. Let's go to the training room. So we're thinking about our patient. She's a 19-year-old female. She's a sophomore, middle distance athlete, 800 runner. She was home for Thanksgiving last week. And, Black Friday, she starts developing some like upper respiratory symptoms, feeling run down, sore throat, headachy, and febrile. So she went to the urgent care. Her COVID was negative. Her flu was negative. And so she just kind of convalesced over the weekend, came back to school, thought she might be a little bit better, but then just completely fell asleep all through class this morning, still is just feeling fatigued and just not herself. So if we're thinking about this person and we're thinking about, what clinical symptoms we're looking at, well, I think about in terms of mononucleosis, I have to think about the Haglund criteria. Now, before we use eponyms, we should know who the person is, because we don't want to use eponyms of people who probably shouldn't be remembered. So our Haglund criteria, Dr. Haglund, he was in Hawaii during Pearl Harbor. He was in Normandy he was running the Normandy field hospital in World War II, worked at West Point for quite some time. And then after his military career, ended up in Emory. He coined this diagnostic criteria for infectious mononucleosis that we still use quite a bit today. And that's your fever, your pharyngitis, and adenopathy in conjunction with a CBC differential that shows greater than 50% lymphocytes and greater than 10% atypical lymphocytosis, and that it's confirmed by a positive serologic test. This is exceptionally specific. It's not at all really sensitive at all. But kind of thinking back to our track athlete, well, yeah, this might start to fit, well, we got to kind of think a little bit more outside the box though. And so when we think about our typical presentation outside of Haglund's criteria, well, you're also seeing some fatigue, some malaise, sort of abdominal pain, that pharyngitis being the most common. Speaking of, we start our exam and this is what we see. And she's got this tonsillar hypertrophy. She's got an exudate that's about gray-white in appearance. And when we think about mono, well, that's about 50% of cases. So 50% of those with mono are going to demonstrate this exudative pharyngitis. But again, that's not overly specific because you see it in strep and gonococcal pharyngitis and HIV and your run-of-the-mill viral illnesses. In mono, you usually see it as white-gray. It can be green. You can see some tonsillar hypertrophy versus necrosis. And when you look at the palate, you may start to see some petechiae. That has one study that suggests that it might be indicative of someone who's going to have a longer disease course, but that's only been seen in one study. The big thing to know here is that, that those tonsils were pretty big. And so severe tonsillar enlargement can occur, and that can cause airway compromise. So something to be on the lookout for. Moving on her exam, well, we start to do, we're thinking about our pharyngitis and we're thinking about our lymphadenopathy. So we move on to the neck and kind of feeling along and feel some lymphadenopathy, and you look and so, wow, she's got some pretty big lymph nodes in that posterior chain. And that's classic. But when I'm thinking about an exudative pharyngitis and a cervical lymphadenopathy, I'm also thinking about strep, right? So how specific is it? Does posterior versus anterior lymphadenopathy, does it really matter? And luckily, Mark E. Bell down in Georgia, in his lab, Dr. Kai, they did an interesting study last year looking at the accuracies of what are our signs and symptoms and some of our CBC data in identifying infectious mononucleosis. What increases our likelihood here? So he looked at a bunch of signs and symptoms. I really want to look at lymphadenopathy. And so here what you can see is the posterior cervical lymphadenopathy is your top line, and it increases your likelihood. Your likelihood ratio is about 3.16. Your diagnostic odds ratio is about 5.2. Those are pretty good, as opposed to 2 down. Here you got your anterior cervical lymphadenopathy on line 3. What I want to draw your attention to is the axillary or inguinal lymphadenopathy. Is the likelihood ratio, the diagnostic odds ratio, and the specificity are pretty similar to that of posterior cervical lymphadenopathy. And this was one of the things that I kind of, when I learned when we were going through the evidence to update the position statement, this is one of the big game changers for me, is that, I was focusing on the neck, think about posterior cervical chain. This axillary and inguinal addition, I think is pretty game changing in terms of, is this strep, is this mono, and kind of leaning me one way or the other. When we think about the rest of her exam, skin is normal. And when I'm feeling her abdomen, she's soft, she's got normal active bowel sounds. Her left upper quadrant's maybe a little tender. It's maybe a little full. I don't really feel the spleen. I don't know if I've ever actually felt a spleen, to be honest, unless they're giant. We're not really good at that kind of exam, but maybe there's something there. Okay, let's think about this here. So in mono, we think about the mono rash, and that's your maculopapular rash after inadvertently giving someone who's got mono amoxicillin. It can happen without the use of antibiotics. And there have been case reports of your macrolides, your fluoroquinolones, and your cephalosporins increasing like your risk of developing this mono rash. You can get petechiae, and that can be more indicative of some of those more serious complications that we're going to talk about a little later on with mononucleosis, but making sure you're doing a good skin exam, looking for any rashes. And then get into the belly exam. So if there's something I can hammer home for you tonight, it's that splenic enlargement is universal in infectious mononucleosis. Everybody's spleen is going to get big. And as clinicians, we are all terrible at finding the big spleen. So our sensitivity and specificity of the physical exam in assessing for splenomegaly is not great, and the inter-rater reliability is poor. So the thing to think about is, your care signs. So that's when you're pushing on that left upper quadrant, and if it's causing that left shoulder pain, that tip of the left shoulder, and that symptom tends to be worse when the patient's supine, that can be more indicative of that diaphragmatic irritation from splenomegaly. There have been case reports of people inciting a splenic injury when doing an abdominal exam. So the bottom line is, do the exam, do a gentle, careful exam. Don't go crazy. And if you don't feel anything, that doesn't really it shouldn't lower your suspicion of mono in these cases. All right. Well, so she's got a tonsillar exudate. She's got tonsillar hypertrophy. She's got posterior lymphadenopathy. I'm thinking mono, but what do I do next? Like, do I get pictures? Do I get labs? The coach is already asking because the meets start this weekend and she's one of their leading point scorers. I don't know what to do. Well, let's start with labs. Okay. And when we think about laboratory assessment in mononucleosis, there's a few ones we think about: the heterophile, the monospot test, your CBC, your antibody testing, your viral capsid antigen testing. And then something interesting that I think is coming down the pipeline that we might see more of is this AST and ALT, your transaminase assessments, to try to help you with your clinical decision making. So again, trying to talk a little bit about heterophile antibodies. So your abnormal B cells that are have undergone their transformation and that are now infected with EBV, they're going to produce this heterophile antibody. And so in the heterophile antibody test, essentially you have a card, and this card has these either latex beads with a red cell antigen, or they have test red blood cells on them. And you add in the patient's serum. And if you have this heterophile antibody, you're going to have the antibody bind to the antigen, you're going to get clumping, and you're just going to have the speckled or heterogeneous appearance of the solution. And that's going to be your positive heterophile test. If you don't have that antibody, well, then there's nothing to cause the clumping. You're going to have this homogeneous solution of your test. So let's think about, well, if maybe it's not that I don't have the heterophile antibody. Well, maybe I just don't have enough of it. And so early on in disease courses, this heterophile antibody test isn't really reliable, and you're going to have 1 in 4 have a false negative in that first week. Now, second week, that drops to like a 5 to 10% false negative rate. So it becomes more reliable the later you are on in the symptomatic course of your patient's disease process. And then, kids are not little adults, right? So it's not really a reliable test in kids, specifically under 6. It's just, you're not going to produce that heterophile antibody. The other thing to be considering is that there is a risk of a false positive test and other reasons that you could have a heterophile antibody produced. Hematologic malignancies, autoimmune diseases, other viruses like rubella, HIV, or toxoplasmosis. And people who have mono, they will produce heterophile antibody for a year after the resolution of their symptoms. So if someone had, a small, upper respiratory infection 6 months ago, and now they're coming to you and they're sick and they've got a positive monospot, well, maybe they had a positive, they have mononucleosis a little earlier, and now that they're now being tested again, it's still giving you that false positive test. So something just to be aware of when you're looking at these tests. So that's our heterophile antibody. And when we look at our other tests, we look at our CBC. And thinking back to Hagelin criteria, you're looking at your differentials of your white blood cells here. Dr. Kaigan, he did a great job looking at different parameters. And when we kind of zoom in here and we look at our highlighted one, that is the Hagelin's criteria, when those parameters are met, the likelihood ratio is 50. So it's much higher suspicion that your athlete has mononucleosis when their CBC differential has a greater than 50% lymphs and greater than 10% atypicals. When you're looking at those in isolation, the likelihood ratio is much lower. The specificity is still rather high at 94% and at 93%. But even just having a generalized lymphocytosis greater than 4, your specificity is pretty high. It's still increasing your likelihood ratio quite a bit with these individual tests. The gold standard confirmatory test for infectious mononucleosis is your antibody testing. So, and this is also the same way that if you are thinking maybe this is a CMV mononucleosis, you're getting your CMV panel, you're going to get these antibody tests. So when you think about your viral capsid antigen, your IgM is going to be your early phase. And that's going to, as the early signs of infection, it's going to you're going to start to develop more IgM, and that's going to peak about 3 to 4 weeks. And then it's going to start to disappear about 4 to 6 weeks after the onset of symptoms. Your IgG is going to start to show a little later in the disease course, about 2 weeks in, and then at 2 to 4 weeks, it's going to start to peak, and then it's going to persist for life. Your Epstein-Barr nuclear antigen antibody, that one's going to show up much later, about 2 to 4 months after your symptoms begin. And in theory, that persists for life, although we do tend to see that it is possible that people's eBNA antibody does tend to kind of go away. If one of them is going to disappear, that's going to be the one that does. So if you get your EBV panel, your acute EBV panel, and their IgM's negative, well, they IgG's negative, they've never had mono, they have no prior infection. But, you're thinking back to that patient who, well, he had a URI 6 months ago, maybe he was a little sick 6 months ago. Is this a real monospot? Well, if he's got IgM, yeah, it's real. But if he's got only IgG or only a positive EBNA, well, that's probably leaning towards a past infection and he's not actively experiencing mononucleosis. So I think this is really interesting. So our AMSSM colleagues out in California, doctors Wang, Kusman, and Huang, they did this great study where they followed varsity athletes for 4 years. And if there was any concern for infectious mononucleosis, they got all of the studies. So they got EBV titers, monospot, CBCs, and then they got LFTs. And what they found was that of the people who had true acute infectious mononucleosis, 100% of them had LFT elevations. Of those who didn't have mono, only 2 of the like over 150 to 200 people who were also in this tested cohort, only 2 of them had LFT elevations. Looking at the mono spot, they had 21 false positives, 3 false negatives, 12 true positives. Their positive predictive value was about 36.4% with a specificity of 90.6%. It's a little less than what's typically reported in the literature. The positive predictive value is historically presented at more like 50 to 60%. And when they looked at the CBC data, that greater than 10% atypical lymphocytosis, only 2 of the cases had a greater than 10% atypical lymphocytosis. So I think this needs more study, and they cite that, you know, the antibody testing is still your slam dunk confirmation gold standard, but I think this is something that warrants more study, and it'd be interesting to see as we learn more if this becomes another tool in our toolbox to try to determine, does someone have an acute mononucleosis? All right. So our patient, we get a bunch of labs. You know, she's 5 days into her disease course. Her heterophile antibody is negative, but she's got a 70.3% lymphocytosis. She's got 20% atypicals. That and alone, that's our likelihood ratio of 50, our specificity of 99% that this is likely mono. She's got LFT elevations, and we threw in there the VCA, the IgM's positive. All right. So our athlete has mono. What do we do now? Well, do I need a picture? Do I need, you know, as we mentioned, like really early on, you know, the thing we worry about here is splenic rupture, splenic injury. Do I need to get a picture of the spleen? And, you know, when I consider imaging, I think, okay, what question am I trying to answer? Why am I getting the picture? What's the best way to get the picture? And is it going to change my management? So when we're thinking about the spleen, do I need imaging? Well, how would I image the spleen? Ultrasound's highly reliable. It's low cost. It's widely available. You don't irradiate your patient. It is user dependent. You have to have someone who knows how to measure the size of the spleen, look at the spleen, interpret the results. But it's available at the bedside, right? CT scan is the most accurate assessment of splenic size. And if you're at all concerned about splenic complications like a splenic rupture, hematoma, infarct, then that's the preferred method. And so it'd be an IV with IV contrast rather. So you can see here your axial and your coronal views of capsular hematoma and splenic rupture here from some recent case reports. So, you know, going back to it though, I was like, is it going to change my management? Well, does my patient have splenomegaly? Well, the answer is yes, right? So again, foot stomping, everyone's spleen gets big. So Dr. Hosey did this study that where he basically got baseline ultrasounds on 1,800 athletes to determine their baseline spleen size. And then he followed them, and those who developed mononucleosis, well, he remeasured every few days and followed the trajectory of their splenic size. And what he found is that everyone's spleen got bigger by about a third. And that ranged from anywhere from like 10% increase to 95% increase in size. And by day 12 to 13, that was the average time that it took from onset of symptoms to splenic enlargement, like peak. And everybody's peaked by about 23 days. So everyone's spleen gets big. It peaks about 2 to 3 weeks, and then it starts to decrease in size. But when we're talking about a spleen size, well, what's normal? And, you know, we can either look at this based on volume or based on longitudinal diameter. And the classically accepted numbers are less than 12 centimeters in length, 7 in width, 4 in depth. But, you know, a lot of our normative data is based on healthy Caucasian volunteers, both in the adults and the pediatric population. And does that matter, the fact that we only have like one facet of our society that's represented in some of this data? So Dr. Hosey, again, he had done this other study where he looked at spleen size based on race and gender. And even when controlling for height and weight, African-American participants in his study found that they had smaller spleens as compared with their Caucasian counterparts. And that was consistent even if in the history of mono or no mono prior to their enrollment in the study. And then, you know, so there might be some differences here that we're seeing based on race and then normalizing for height and weight. But now let's look at height and weight. And so when McCorkle and his group looked at the tall athletes, so athletes at an average of 6'4" for men or 5'10" for women, they had larger spleens. And I guess, yeah, that makes sense. When you're looking at that normative value of 12 centimeters that I just quoted, well, that's less than the average here in his study. So when we're looking at our athletes and we're saying, well, maybe their spleen size is big, I don't know how you find that number, like what's constituting big or small at that single point in time, because you don't know a baseline and you don't know where they are in their disease course. So just going to show that your volleyball players like David Lee, who's 6'8", or Simone Biles, your gymnasts who are 4'8", there you can't take everybody and lump them into the same kind of grouping and expect the same results for everybody. All right, so formal recommendations. So this is going back to the fact that the blue side is draft form. The OH side on the white side is what is currently the guideline that we're looking at, and the CAQ is based on for your upcoming board exams. So that one-time imaging of the spleen assessment for splenomegaly, that's not of use whatsoever. So it's not going to tell you what you need to know. So it's not recommended. Routine imaging, not necessary. If you're going to evaluate for the spleen size, ultrasound is preferable because it's easy, it's cheap, it's non-invasive. But if you're looking for splenic injury, you need that CT scan with IV contrast in order to get the maximum amount of information to be able to appropriately manage that patient. This is the exact same thing that we're recommending in the new proposed guidelines. So nothing really reporting there to that in terms of changing. All right, so we didn't get a picture, but we've now got a patient with mononucleosis. We got an athlete in season. How do we tell, what do we tell her to do? Well, we tell her supportive care, right? So hydrate. If you're febrile, using Tylenol versus judicious NSAIDs, hand hygiene, your typical things that you would tell someone for supportive care. The big things are you're going to restrict them from activity, because this is the thing that you're trying to avoid. You're trying to avoid that splenic rupture, that serious complication. And that's going to require avoiding excessive Valsalva or trauma. So that's why we insist upon that activity restriction. So to include running, weightlifting, things that are going to increase the pressure or potentially increase your risk of splenic injury. And then a lot of this is education, talking to your patients about disease transmission, saying, don't be sharing water bottles, don't share food or utensils while you're sick, because you don't want to infect the other people around you. Saying this usually goes away on its own. It takes on average about 4 to 8 weeks. A lot of people get better faster. Some people have a prolonged disease course. What we typically find is the younger the patient, the younger the athlete, the shorter their disease course, but this can take several weeks to resolve, and setting your athlete up for that is, and your coach up for that is very, very important. Can we do anything to speed things up though? Like, how about steroids? Will steroids make things a little bit better, a little bit faster? Nope. And so the only real indication to use glucocorticoids is when you're in that tonsillar hypertrophy, that's impending airway obstruction type scenario. So that's the indication, and that's usually more of your inpatient scenario. So no use, no for routine outpatient management of mono. Maybe antivirals, it's a virus? Nope. So there's a Cochrane study that said, no, it's not going to be helpful in getting your athletes back any faster, or making people feel any better any faster. And the same thing goes for antibiotics. And so the only real indication is if you're part of that 30% who have a co-occurring strep, yeah, that would be a reasonable thing to provide antibiotics for. Just avoid your penicillins, avoid your amox, don't give them the mono rash. Now, fewer than 1% of people who have mono are going to end up with a severe complication that requires hospitalization. Of that 1%, the most common reasons that people are hospitalized is your splenic injury, severe hepatitis, or that upper airway obstruction or severe dysphagia, inability to tolerate oral intake. And so those are the things that you kind of really watch out for. And you're saying, hey, if you're feeling like worsening belly pain, if you're having stridor, if you're having shortness of breath, difficulty swallowing, hey, you got to let me know, or you got to go to the ER, and giving your appropriate return precautions. Things that can happen, your hemolytic anemias, your thrombocytopenias. That's why doing your skin exam and looking for any evidence of petechiae becomes very important. Looking for, myocarditis, acute interstitial nephritis, encephalitis. These things all can happen, but they're exceedingly rare. So splenic rupture. This is the severe complication that we as sports docs. This is the reason we hold people out from sport. It's, again, enlargement is universal, rupture is rare. And so it accounts for about 0.1 to 0.2% of all diagnosed infectious mononucleosis cases. In Reality, this number is probably a little bit higher that we're reporting here than is true, because what we tend to see is that, this is all the people that we diagnose with infectious mononucleosis. There's plenty of people who were sick for a few days and they go on in their lives and they never actually get the diagnosis. The risk of rupture has not been found to be dependent on how big the spleen gets, how severely ill people feel. It's thought more to be dependent upon the degree and the speed at which the spleen enlarges. But that still it's more of a weak association. When splenic rupture occurs, it's a big deal because there's a high degree of morbidity and an increased mortality risk. So you're risking multi-organ failure, DIC, splenectomy, and all the sequelae that occur with that. And chronic pain, we'll get into that in a little bit. Studies on mortality risk vary. Some studies show as high as 9% mortality risk. Others shows that none. So I think it's a little bit dependent on your population. So these are two studies that were done in the past 5 or 6 years that are looking at what's your actual timeline of splenic injury from the onset of symptoms. So the one on the left shows that's a study, a retrospective case series looking at insurance data and CPT coding data within the military system. And basically what it found was that on average, it was about 11 days to splenic injury on average, or the mean there. So by 75 percentile, by your 3 weeks, what do we typically hold people out for? That 21-day restriction, you're capturing about 75% of all of your splenic injury events. And then if you wanted to capture 90% of all splenic injury events, that happened by 31 days. The interesting thing to know in that this data and in the Bartlett study on the right, the overwhelming majority of these ruptures occurred without any sort of inciting trauma. Between 80 and 86% of these ruptures were atraumatic in nature. The Bartlett study back in 2016, that looked at reported case reports that were found in the literature, and what they found was similar in numbers in terms of their average time to rupture was a little less than 2 weeks, and then they're capturing the 75th percentile is a little bit more like 3 weeks. Again, but their tail, they found that there were evidence of splenic ruptures well into 62, past 8 weeks, and so there are some outliers in both of these cases. The return to sport is something that I kind of want to draw everybody's attention to, because this was done in the retrospective case series, and they found that overall they had 42 cases of splenic injury, 35 reported on ability to return to sport, and only about 70% of those cases was the person affected able to return to their prior level of athletic activity. Of the 30% who were unable to return, 10 total cases, 8 of them were unable to return due to chronic abdominal pain. And two of those 8 actually underwent splenectomy, trying to fix their abdominal pain, and didn't do anything, didn't help them get back. So it can take up to 6 months if they're going to get back, if your athlete's going to get back after this type of event. It can take 6 months to get there. But after about 6 months, the likelihood of returning to sport, at least in this population that we found in our study, was 0. And so this risk, thinking about a college athlete having a splenic rupture event and then not being able to return to sport due to abdominal pain, I think that's something to be considerate of when you're kind of thinking about these return to play decisions. So speaking of, when do we return to sport? All right, 2008, activity restriction. It is okay to resume light activity 21 days from the onset of symptoms. So that's the foot stomp. That is the answer for the CAQ. That is the guideline that we've had since 2008. In order to return to light activity, your athlete has to feel clinically well. They have to have a good energy level. They have to feel like they're good to return to sport. The proposed draft version that we have right now, that we're thinking that we're currently pushing forward, is that given what we know about the risk of splenic injury, it is reasonable to try a supervised, non-impact, low-intensity activity 2 weeks from the onset of symptoms. Again, providing your athlete feels clinically well, is afebrile, has an improving clinical exam, and that they feel ready to return to play. Okay. The big thing is that, having a good relationship with your athlete and that shared decision-making model is incredibly important when talking about returning to play. And so making sure that they feel ready, and then looking at that 2 weeks instead of 3. That's kind of the proposed draft version that's coming down the pipeline. Returning to contact, our current guidelines say that a time frame of at least 3 weeks is commonly recommended. And so that's saying that, returning to light activity, going okay, and then progressing back into contact. Again, assuming that your athlete is feeling clinically well, normal energy level, and is able to get back into doing the things they want to do. Knowing what we have kind of just already talked about with our risks and looking at return to activity, are the proposed guidelines say that at the time we don't have a clear understanding, we don't have a slam dunk evidence to say, yes, at this time we're good to go. But given the risk of splenic rupture, a time frame of at least 3 to 4 weeks from the onset of symptoms is recommended. And again, highlighting the importance of shared decision-making and talking with your athletes about the risks and benefits of going back and making sure that they're feeling clinically well and ready to go back. The role of ultrasound, again, the things that we want to think about are, if you're suspecting a splenic injury, you should be looking at a CT scan, but you can scan and you can use ultrasound in order to determine, if you're seeing evidence of a splenic injury. Okay, that's again that point of care benefit. If you're looking to use ultrasound to advance recovery or an advanced return to play, the most important thing is serial imaging. So you need to be looking over the course of several days, and you should be able to look for decreasing size or, being able to look for appropriate decrease in splenic size. So again, not that single picture in time, but that serial imaging. The updated guidelines that we propose are that imaging of the spleen is not necessary for routine management, but in a situation where an athlete's considering an early return, serial ultrasound can be considered to confirm that the athlete's spleen is actually decreasing or remaining stable in size. And again, that 1-point timeline has not been shown to be beneficial. All right. So, this becomes the big thing is, having that conversation with your coach. They're out for the meet this weekend, right? So they're 5 days into their symptoms in your training room, that they're going to be out and telling a coach at least that 21 days. So they have to be feeling ready to go, and 21-day restriction from sport. That's our current guideline in terms of keeping kids safe and mitigating that risk of splenic injury. All right, so EBV, exceedingly common. Our immune system response to EBV is that's what causes infectious mononucleosis. If you have a suspicion, really be looking for the axillary or inguinal lymphadenopathy as a clue to maybe draw you towards a mono versus something else in your differential like a strep. Thinking about your clinical context for your monospot, your CBC, your LFTs coming down the pipeline. You can use your viral capsid antigen, your antibodies for confirmatory labs. If it walks like a duck and it talks like a duck, but the EBV panel is negative, don't forget CMV and getting a CMV panel. There is no role for routine imaging in the diagnosis and treatment of mono. Supportive care, activity restriction, education for your patients and for your coaches, watching for those complications, and return to play 3 weeks if you're taking the boards, maybe 2 weeks coming down the pipeline, depending on our proposed guidelines. Stay tuned for more. And figure we'll start off with speaking of boards, we've got a question here. So Andy, if you can help me out with the poll, but we have a 16-year-old male basketball player who's presenting with 5 days of a sore throat, fever, and fatigue. He's got an exudative pharyngitis and an axillary lymphadenopathy. His playoff game is this weekend. He wants to play. And so which of the following tests is the most sensitive and can assist with your return to decision-making to allow the athlete to play? think we got quorum. So our answer is, okay. So we're getting a combination. So we're looking at our viral capsid antigen is the correct answer right there. And the reason, and so a lot of people were going between the IgM and the monospot. And so the thing to think about is, going back to that monospot in the first week of illness, the monospot is going to have a 1 in 4 false negative rate. So it's not quite as good a test as your viral capsid antigen in early disease. So the answer was your viral capsid antigen IgM. Okay. So just wanted to give a thank you to everyone who's been on this AMSSM writing group for the updated guidelines that are forthcoming, and including our own Dr. Statuta here. And then I will happily take any questions that y'all have.
Jill, thank you. That was wonderful. I do have it. That was really well done. And I think it just, in hearing it, even though I've been reading and part of the rewriting group, to hear it proposed and taught, it just goes to underscore it's a complicated syndrome, right? No two cases are quite the same. And so thank you for reviewing that. I have a few questions that have come up, and I'm just going to start with one that states, at what point would you consider workup for alternative causes or underlying immune system deficiency in an athlete that has recurrent bouts of symptomatic IM? Have an athlete who has been diagnosed 3 times in 3 years. Oh, so this individual has had an athlete who has been diagnosed 3 times in 3 years and only once by that person. So at what point would you consider alternative workup?
I think that's an interesting question, because that reactivation of infectious mononucleosis was something that we saw a couple times when we were reviewing the literature. I think what the question I would have, having an athlete diagnosed 3 times in 3 years, I would be curious about what methods were used to come to that diagnosis. Were they all IgM? At which point, I think after the third bout is the time that I would say third time's a charm, in terms of talking to kind of our allergy and immunology, and like why is this athlete continuing to reactivate, or are they not making IgG and they're only being able to mount that initial immune response, versus are they being diagnosed with monospot? Again, at 3 years, I wouldn't expect a monospot to continue to have heterophile antibody production, but I think that would be at third time in 3 years, I would absolutely say that it's time. But I think I would need to know a little more information about when someone, is it actually a reactivation or not? I think that becomes the most important question.
Yeah, I would definitely agree. I mean, it's not uncommon to see a reactivation. I mean, it's not common, but it's not uncommon. So one reactivation, okay. 2 in 3 years, that's pretty significant. So yeah, I definitely agree with you.
Yeah.
We have another question here. Good evening, Dr. Sylvester. I'm a second-year medical student at AT Still University. Does your recommendation, excuse me, regarding return to sport depend on the type of sport the athlete plays? For example, difference in return based on football versus tennis?
And so the current guidelines as they stand right now talk about that 21-day restriction, doesn't cite contact versus non-contact in that initial return, and then says that progressive return to contact, after 3 weeks. The proposed guidelines talk about return to cardio and return to contact in 2 different contexts. And so it says, talking about if the athlete feels clinically well and good to go at 2 weeks, you can start them with that light non-impact activity and progressively return them to sport, versus that contact. So football, wrestling, basketball, thinking about should that be more 3 into 4 weeks with that shared decision making model. So I think it allows your cross-country athlete to get back into the swing of things a little bit faster, because when you're looking at your risk of rupture, 86% in the study that we did, that retrospective study, they were atraumatic, An atraumatic occurred at an average of 13 days. So you're seeing that the risk of traumatic rupture was higher later on. And so that's the proposed guidelines are more in like detailed to allow you to have that separation based on sport and based on activity.
Yeah, that makes sense. We have another question right here. In regards to your palpation of the abdomen, how do you be as gentle as you can to not injure the spleen while maximizing the sensitivity of your physical exam?
So I think that's the hard part. So I think it's I mean, it depends on the size of your patient. It depends on, I think I don't particularly push hard when I do my initial abdominal exam. I do gentle palpation, and then I become a little bit more aggressive and kind of doing a little bit more deeper palpation. And if I feel something abnormal, well, then I'm going to pause and I'm just going to try and better characterize that. The other thing you can do is you can actually look at, it's called the scratch test. And so if you use your stethoscope, this is often used on the right upper quadrant to look at the liver. But you can place your stethoscope over an area where you would expect the spleen to be, and then you kind of move, you scratch, and then you scratch a little bit more distally. And when you hear the difference in kind of the tone and in the pitch of the reverb that you hear in your stethoscope, that can be more indicative of, okay, well, there's a difference in density and what's kind of moving there. So I mean, that could be another kind of tool in your tool belt to be able to employ. I think it's, doing your typical exam, but I wouldn't go, if you think something's there, I wouldn't keep going and going and going. I would say, yeah, I feel something a little bit different there, and use that as just another clinical clue.
Yeah. And Jill, so you had mentioned the axillary and inguinal lymph nodes kind of being a little bit of a game changer for you. Tell me how. Anybody who you have suspicion for, do you palpate axillary and inguinal lymph nodes?
Yeah. So I mean, I think about, it's that, is this strep, is this mono, kind of quandrum, like kind of conundrum, like in my head, I'm like, okay, well, I've got axillary lymphadenopathy. Well, that's not going to show up in some of my more common things. So I go to axillary first. I don't really do the inguinal lymphadenopathy exam personally. But I will just go and I'll feel for axillary lymph nodes. And there were about 3 or 4 in the past year where I've been, okay, yeah, I'm feeling lymphadenopathy here. I'm going to actually restrict faster. I think one place where I practiced recently, it took a while for my antibodies to result. I think it's very lab dependent. So if I had to make a game time decision, well, then I'm going to restrict, I'm going to be more likely to restrict them feeling axillary lymphadenopathy, and that's going to increase my suspicion for mono. I think that, that again, you're working with small pieces of real estate. And so if you're going anterior versus posterior chain, I'm not going to trust that as much as like, wow, okay, I'm feeling axillary lymphadenopathy. I feel much more confident in my diagnosis here.
Yeah. This is just a personal question that I have. People get used to practicing the way they trained, based the way mentors have taught and have done it, and institutions have taught. What is your personal lab workup in your current location? What do you do if you have suspicion somebody's been ill for a week and you're ready to dive into the labs?
I usually get, where I trained, again, it took a while to get your EBV panel back. So what I did was I did a monospot and a CBC. After the study on the LFTs came out this past year, I've now started incorporating LFTs as well. And if I see someone who has, a negative heterophile antibody, but who has greater than 10% atypicals and an LFT elevation, I'm going to hold them out. And then, depending on I'm not getting EBV panels on everybody. If it's going to be like a game time decision, yeah, I can get that, and I can get that a lot faster now. But I feel much more confident with transaminases and CBC and a heterophile antibody than I did with just the CBC and heterophile alone.
Yeah.
Again, that's not necessarily, it's based on the evidence we've seen here. I think there's more that needs to be done. Where I am now, I get EBV panels much faster. I get them on the order of hours instead of on the order of days. That makes it much more likely that I will pull the trigger and get an EBV panel, but I still definitely get the CBC, CMP, and a heterophile antibody, and I pretty much know the answer before I'm going to get the EBV panel back.
Yeah, that's interesting because at my institution, it takes a while to get the EBV panel back. So I trained, and I have always practiced to do exactly the monospot, the CBC, and AST and ALT. And what I found is very commonly I'll make the diagnosis based on atypicals and even a slight elevation in the LFTs. And the LFTs are interesting because it's similar to the ultrasound of the spleen. You know, you're getting one moment in time, but if that person is still ill, you can begin to track the LFTs a little bit. And so it gives you a secondary reference point to follow. So I'm not sure in every individual and all the fellows and learners out there listening, but there's a lot to consider. One is the turnaround time for the labs. Two is what is coming up for this individual. How imperative is the time frame? I mean, if they're 2 weeks away from beginning NCAAs or their regional competitions, that's something to consider. And then number 3 is the cost of the different tests. And so there's a lot that goes into play with all these decisions. And that's where you begin to hone what works for you, what do you feel comfortable with, and this recent evidence that's come out, which is really, really helpful.
Yeah, I actually changed my slides to take one study out, but there was a study out of in China in 2017 that looked at it was hospitalized patients with infectious mononucleosis, but it looked at their AST and their ALT and looked at did a ROC curve to determine like what are the cutoffs that I should really be suspicious of this being due to mono, and they weren't high in men. I think, oh man, I think they were like AST and ALT of 48 and 60, and in women we're in the low 30s. So very small elevations, increasing your suspicion.
Yeah. And then so we had a comment in the chat. Do you trend LFTs if elevated and use that in your return to play decision? I've been using LFTs for years, and this Eric Cole is Division I team doc for over 15 years. And I responded already in the chat. I do, especially if they're very elevated. If I have one that's barely elevated, I won't. I tend to follow more of a clinical course. But if they're really high and I'm like, whoa, you know, these are significant, I personally will trend them out if they're highly elevated. So yeah. Jill, in the last couple of minutes, I have a question regarding how do you manage the athlete that you know who is ill, who is saying they feel better? They're for the board purposes, they're at 21 days, and you know this person, but they're telling you everything, and clinically they're okay. How do you manage that? Can you speak to your clinical expertise as to how to guide athletes through this?
So you're asking if someone who's giving you all the lip service, but probably is okay.
Yeah, you still have some suspicion.
Yeah. You know, I tell them the risks. I said, okay, here's why we hold people from sport. Here's, here's what we know, here's what we don't know. And then I would start them, shared decision-making and patient autonomy are some of the biggest tenets that you have to hold on to as a team doc. You have to protect the patient, but you also have to let them be their own person. And I think what I would probably do and what I've done in that situation in the past is started them on a non-contact return and just kept touching base and kind of saying, okay, well, we're gonna start this process, but listen to your body, and you see how they react. And if people aren't ready to go back, even if they're dying to get back in it, when they start to exercise, they may find that they're just not feeling it, and they're just not feeling clinically well enough to do so. So I think what I would do there is I would say, well, why don't we start the process, not jumping into contact immediately, but let's start, hitting a bike, a little bit of light jogging. And because the studies say that, the atraumatic rupture outside that 3-week window is low. The trauma rupture is going to be the higher risk, and that's going to be up to, 31 days or so. So if you start them on a non-contact return to play kind of a few days there, and that's going to let them kind of determine to themselves, are they ready to go back or not?
Yeah, that's excellent. I also, I think this is the value of educating them, just because I think mono is a tricky illness in that like we talked about, no two cases are exactly the same. And so there's nothing magical about the 21 days. And so the new draft that's proposed alludes to that, but there's nothing magical about day 21 or 22. So the body's going to do what it's going to do, what it's ready to do, and just letting the athlete or that individual know, hey, you might be doing great, but if you're beginning to bonk, if your legs are feeling heavy, if you're not feeling it, trust it, come back, talk to us, talk to your trainers. Maybe we just need to take a slower course. That might be something that lets them understand, hey, maybe I'm not totally ready, and not just keep pushing through. So,
and that's why I think saying at least 21 days, because if you make that 21-day hack, great, wonderful. I'm excited, but setting them up that it sometimes people do take longer. The average return time, the average time that people need to feel back to their normal self is 4 to 8 weeks. Is based on the literature that's out there now. So they may not be ready at 21 days, and that's okay. And so setting them up for that at the beginning makes, if they are ready at 21 days, makes it all the better.
right.
But yeah.
And conversely, not all monos are wiped out. They're not dragging in every single time. Many of them are, but many of them won't be. So the person who is at 2 weeks and raring to go, don't be afraid to allow them to have some safe activity to test the waters, and just keep an eye on them, and educate. So I think the key is education, and keeping the doors and lines of communication open for these, for these cases.
Yeah. So I think that's the interesting part with the new guidelines and where they could go. And so I'm excited to see, and what happens in the next year and how things potentially change, and allowing our athletes to kind of maybe get back a bit faster. Again, splenic rupture is exceedingly rare, but it's serious when it happens. And so it's kind of trying to weigh the pros and cons of both sides and do what's best for your athlete.
That's right. Well, great. Jill, in the interest of time, I think we're going to have to wrap this up, but thank you all for attending tonight. And Dr. Sylvester, thank you so much for giving us this amazing talk. And everybody out there, please be on the lookout for the updated position statement, and have a super week. We'll see you next week for endocrinology. Thanks, everyone.
Thanks.
Thanks, Dr. Sylvester.